All right, good afternoon, everyone, and welcome to the seventh session of the Lunch and Learn webinar series. Today's topic is going to be on smokeless tobacco, and our faculty today is Dr. Severson. So welcome. All right, we just have a couple of housekeeping announcements before we get started. So please ensure that you have registered for this webinar. If you have not registered for the webinar, please click on the link. The Learning Assessment 1 does follow the registration. So it is imperative that you do complete the registration and then complete the Learning Assessment 1 that's also connected. A link to Learning Assessment 2 is going to be sent to your email following the webinar. And in order to receive your letter of completion, you must complete both learning assessments. So when logging into the webinar, please make sure you log in as a guest using your first and last name so we can track your participation. So I'm just adjusting this down. If you are signing in as a group, please make sure that you send Eleanor an email with all the lists of your participants. You are more than welcome to join the audio using your computer, using Adobe. If you are having problems with that, then please call into our teleconference line. The number and the code are on the screen. These webinars are going to be live tweeted on Twitter, so please follow us at PF You can follow the webinars using the hashtag #TeachWebinar. All right, so Dr. Severson, PhD from the University of Wisconsin, is currently a senior scientist at Oregon Research Institute. He's a licensed psychologist with over 40 years of experience in intervention and prevention research. Since 1979, Dr. Severson has been an investigator on more than 50 National Institutes of Health grants, researching the development and evaluation of tobacco prevention and cessation. His research involves the evaluation of smokeless tobacco and smoking cessation programs, including web-based cessation, interactive computer-based tobacco prevention programs for youth, and dental office-based prevention for both tobacco cessation and eating disorders. In addition to his tobacco research, he has also developed early screening interventions for aggressive behavior in young children. He is a contributing author of 5 Surgeon General reports and the Global Report on Smokeless Tobacco, published by CDC in 2013. In addition to more than 140 articles in professional journals, he has authored numerous prevention and cessation books and over 30 video, computer, and web programs on tobacco prevention and cessation. He has been elected a Fellow of the American Psychology Association's Division 38, the Society of Behavioral Medicine, and the Academy of Health Behavior. He received the Research Laureate Award from the American Academy of Health Behavior in 2006. And here are his disclosures. This is our disclaimer and the TEACH curriculum. So now I'm going to hand it over to Dr. Severson for the learning objectives and the rest of his presentation.
Thank you. My goals today are to help you be better prepared to help people quit their use of smokeless tobacco. And my learning objectives are in front of you. Essentially, I'm going to focus on kind of some of the clinical work you would do with a chewer, but also I'm going to focus on what I would call public health interventions, that is, interventions that have the greatest reach for helping the greatest number of people. I'm going to talk a little bit about dual use and the effects on cessation, and I'm going to give you some recommendations on pharmacotherapy. So that's it. So let's get started. I think the first thing to know is that there's been a continuing increase in smokeless tobacco use in the United States, and we're seeing it also in Canada. That is, as we've restricted smoking, what we've seen is a decrease in cigarette use and an increase in oral tobacco use. This is particularly true because of the introduction of the new snus products, and these have expanded the sales of oral tobacco products. This has been largely pushed by the fact that the tobacco companies have purchased companies. They see where the growth is, and they have purchased companies that produce snuff and oral tobacco products. And of course, by using the name Camel and Marlboro, they can help people identify the product quite easily. Altria, which is used to be Philip Morris and now is the largest producer of smokeless tobacco in the world, by purchasing the U.S. Smokeless Tobacco Company, they make both Skoal and Bandits and Copenhagen and very popular products. So what you see now is that tobacco companies are heavily invested in increasing the sales of oral tobacco. Well, the thing to remember is that these oral tobacco products contain very high levels of nicotine. And of course, nicotine is an addictive drug, and it meets all the criteria of being an addictive drug. These criteria are listed in front of you in terms of inability to abstain, persistent craving, buildup of increasing tolerance and the need for more of it, and experiencing serious withdrawal symptoms when you're quitting. So essentially, I just want to emphasize that oral tobacco, snuff and chew, is highly addictive, and that when you're treating these people, they experience the same withdrawal symptoms and the same kind of difficulty in quitting that you're going to see with smokers. Well, a thing to remember is that this is a very diverse group of users. Historically, this might have been ranchers and loggers and people in certain occupations or in rural communities, but it's really reaching all parts of our culture now. And so what I'm seeing is I'm treating lawyers and firemen and policemen and a wide range of white collar people who have taken up the use of oral tobacco. And so I think I just want you to remember that this is a very addictive drug, and it really affects people, and it's people that we're trying to help, and it's a very diverse audience of people. So the question today is, what can you do to help people who are addicted to chew? And that's really the reason we're together here today, and that is, what would you do? How can you do it? What's the most effective way to do this? And I think of this as really in two areas. One is, of course, motivating people, encouraging them, supporting them, and motivating. That is helping people make the decision to quit and increasing their motivation to make an effort to quit. The second kind of thing we're going to focus on is how do you support them? So let's assume they're motivated. Let's assume they've made a decision and they're interested in quitting. How do we support them when they're ready to make that quit effort? So this is a slide that kind of captures some of what I'm talking about here. In terms of motivation, I think we want to educate people about the risks of using these products. And there are some serious risks, not just the addiction to nicotine, but also the very detrimental oral effects due to regular use of oral tobacco. We want to promote success. Part of the motivation can be that people can make small changes and experience confidence that they have the ability, the self-efficacy to make a difference. So we want to help them learn from the failures as well as their successes. In terms of support, I think we want to really make it easy. By that, I mean we want to make it accessible. I'm going to talk today about public health interventions, reaching out to people. How can we make cessation services accessible to everybody? You're also going to hear from me the strong evidence that support is a very important factor in increasing cessation rate. That is, what we see is that support by family, support by friends, support by spouse, we have clearly shown that what we need to do is help people be supportive. We need to help give them ideas about how they can best support the way to quit. And the bottom line on this is that there is no single approach that's going to work. I think people have to have an individualized program that they feel is going to work for them. And hopefully today I'll give you some of those ideas and some of the plans. I think of spit tobacco treatment as a four-step process for quitting. Obviously, we're going to talk about today is getting ready. How do you help a person get ready to quit? How do you help them make the plan to quit? And what are some of the options in that? How do they deal with withdrawal? And again, we're going to talk about NRT, nicotine replacement therapy, but we're going to talk about other ways to deal with withdrawal also. And ultimately, the goal, of course, is to stay off chew. This is very similar to what you'd expect to see with treatment of smokers, but I'm going to point out a few small differences that I think are critical that make it kind of a unique cessation program when you're dealing with chewers. Well, first step is getting ready. I think of this as three steps. How do you assess the level of addiction to tobacco? How do you, and of course, I think it's very important to review the reasons for wanting to quit. And I really encourage people to think about those reasons, to write them down, to share them with both you and friends and family, and being very clear what their motivations and reasons for wanting to quit are. This is kind of a decisional balance, and they kind of weigh the benefits of chewing versus the risks and benefits of quitting. But I think you need to really have these reasons clear. And you also need to assess readiness. And I'm going to show you a tool for assessing readiness to quit. So on the first part, assessing dependence, we typically modify what we know as the Fagerstrom dependence scale, and we modify it for use with smokeless tobacco. And typically this asks for the frequency of use, how much people use, do they intentionally swallow the tobacco juice, do they use it when they're sick or even having mouth sores, and how soon after waking. Of course, within 30 minutes of waking is an indication of higher level of dependence. We also find higher levels of dependence if they're dual users and if they use it in situations where it's not allowed. We've developed our own dependence scale, which is shown here, and I'm happy to share this with you. I'm also happy to send this to you by email or give you the scoring system. But essentially, what we look for here is not just the traditional things of dependence, but we look for is motivations. What are the benefits that people feel they're getting from the use of the chew? So in other words, for example, do they use it when they get anxious? Do they find themselves using it when they get drowsy? In other words, is it used for making them alert? Do they use more when they're worried? And this is again part of anxiety. Do you use more when you're rushed or anxious to do things? And do you use it more when you feel the need to be alert? We find that these factors are very important to understanding some of the benefits that people are getting and some of their motivation for continuing to use the products. I also recommend using a readiness ladder. This is a pretty simple thing to use, and you can put it on any intake form that you want. It's a 10-step ladder, and a person simply circles the number that corresponds with their level of readiness. So, for example, if they circled 6, they would say, I'm thinking about quitting. But if they circled an 8, it means that they really have cut down and they're seriously ready to quit. I think I want to emphasize again that everybody needs to have support. And I want to talk about some of those methods, that we're going to talk about methods for quitting. And we're also going to talk about the need for drugs. I call it drugs, but really nicotine replacement or other substitutes can really help people quit in a much more effective way. So the bottom line is everybody needs support, but some people additionally need methods and ideas for how to do it, and some people need substances or drugs, which we'll talk about both of these. Now, when I talk about support, one of the things we find is that the vast majority of chewers are men, and what we often have tried to do is help the partner, in this case usually a female, help them with positive ways to be supportive, complimenting people, expressing confidence, being supportive in a positive way. And we have what we call we call it do's and don'ts really for the supporter. And that is some positive things that they should do, and maybe some things they really shouldn't do. So what we find is that if the partner is nagging or negative, then it doesn't help in the quitting effort. It actually undercuts it. There are different ways to quit. The typical way is, of course, cold turkey, but some people prefer a kind of a reduction method in terms of getting ready for quitting. This can involve brand switching, that is switching from a high nicotine brand to a low nicotine brand of chew. It can be fading, that is that you can use less and less chews. You can set a goal of having, let's say you're using 10 dips a day now, and your goal could be to cut down to 5 dips and then cut down to 2 dips. And what you're doing is fading out the nicotine before you make a full quit effort. Another effort idea is blending, where you take a non-nicotine substitute, which we call fake chew, which is usually an herbal product, and you blend it together with the product that you use in an effort to reduce the amount of nicotine you get. All of this is an effort to simply get ready for the full quitting of the tobacco. I see there's a couple problems on this slide, but this slide simply shows you that some of the products have very high levels of free nicotine in them, and some products have very low nicotine. And so if you're advising people to use different brands, you typically have people that are using high nicotine brands. You might recommend that they switch to a low nicotine brand as a preparation, if you will, for their getting ready to quit. I like to focus on what I call public health interventions. And the reason for that is we want to have the greatest impact on people. We want to reach the most people. And so impact of a program is reach, that is how many people can we get to the treatment, and then times the effectiveness. That means how effective or how successful our program is in helping people quit. So one way you can think of impact is reach times effectiveness. And I'm going to show you some public health interventions today which have very high reach, and they have modest to sometimes very good effectiveness. But the bottom line is we can really help people more. 95% of people who choose to quit do so on their own, but we need ways to support them and provide help to them. One way, of course, is through dental clinics. And we have been very successful in using dentists and dental hygienists to provide brief interventions in their offices. And the reason that this is so successful, I think, is that oral tobacco has a high impact on your oral health. That is, that a very high percentage of people will have lesions in their mouth or oral effects from the use of these tobacco products. Secondly, dentistry, you're in there for 40 minutes to an hour on a hygiene visit, and you have a chance for the hygienist or the dentist to talk to you about your tobacco and relate it to your oral health. And again, about half of all tobacco users will see a dentist in any given year. Well, as I've already mentioned, oral health problems are prevalent for chewers and dippers. And what you see here is that it leads to stain, halitosis, caries, periodontal disease, including bone loss. And actually, people will lose their teeth where the tobacco is kept. And most concern is lesions and a possibility of oral cancer. So the typical intervention that we do is we ask the hygienist or dentist to check for tobacco use, asking the patient, relate their oral exam to their tobacco use, provide some direct advice to quit, hopefully give them some take-home materials to leave with, and follow up at the next visit. We have used this program successfully in 7 clinical trials, and every single trial has shown a very positive effect of these brief interventions. So obviously, if you could get the dentist and hygienist to work with you, I think you could have a great impact. We've also done it in the military. Here what we did is we identified the chewer in the dental clinics, and we did it in all branches of the service. And then we simply phone called them, and we did phone calls to provide support and mailed some quitting materials to them. And the materials we sent to them typically were a book called Enough Snuff and a small video. But this is a cessation guide which has been very successful. This is a military version of it, but there's also versions for civilian populations as well. But look at this outcome. I mean, it's quite exciting, actually. Using an intent to treat, which is a very conservative way to look at this, we got very high quit rates at both the 3-month and 6-month for the military personnel that were receiving this brief intervention. Again, counseling, brief counseling, some supportive materials, and a phone call was the intervention. And you can see 25% were reporting quit at 3 and 6 months. Very powerful stuff. Well, we also have tried to help people quit on their own, and there's different ways to do that. We think that's kind of what we call minimal contact, which is a self-help guide. We've created videos, and also we've just, as I mentioned, we've done phone calls where we just train people to call and provide support. And most of this support is just generalized support. It's not really highly trained, specific, step-by-step quitting. It has more to do with providing the support to somebody who's really trying to quit. So you see here, here's a sample study here of a self-help quitting program, comparing just getting the manual, that little booklet you saw, versus getting that booklet plus receiving these phone calls from the counselors. And you can see that the phone calls from counselors significantly enhances the quitting. So again, providing brief support, providing that kind of phone calls. And again, this could be telephone support from your helpline as well, in addition. We've done programs like this, and our basic takeaway message is that phone counselors are very influential in helping the chewer to try these techniques and to provide support to them when they're going through the withdrawal. And we think this represents a very low-cost public health model that can be widely disseminated and reach out to people. We've also done web-based programs. Again, I think the web-based programs provide more reach for people, particularly in rural areas. People don't need to travel to meet a counselor. They're available whenever you need them, 24/7. Very low cost and very high reach. And we have found they're quite attractive. The only negatives we found is that people tend to not stay on the program very long. It's selective engagement, and it pretty much relies on them themselves kind of doing it on their own, although you could enhance this with telephone support. We had a website called chewfree.com, and we did a randomized trial with 2,500 users. And essentially, we compared this kind of enhanced condition, which is a personalized cessation program offered by the website, versus a basic condition, which is just kind of text that you'd find typically on the web. And this is kind of typically what it looked like. This is the chew-free enhanced condition. And you see up here, you can see a person here who is either giving a testimonial or a counselor providing support. And the person makes a plan to quit, and then once they've set a quit date, then they click on a link here, which is called Staying Quit. That program was very successful. You can see here that, again, a very conservative analysis shows that at 3 and 6 months, over 40% of people were reporting that they had quit all tobacco. And this is through a web program. Again, no personal contact, just people who really sought help through the web and allowed us to do follow-up with them. We then did a new web program called mylastdip.com. That program, by the way, is still live, and I encourage you to go in and use it. It was originally designed for young users. When we did the trial, we were looking for young users, 14 to 25. Again, we randomly assigned them to this enhanced versus the basic condition, which is really kind of a text-based condition. Again, now remember, this study was done on young chewers, which are often the most difficult to quit. In this program, we tried to make the website a lot more interactive and a lot more interesting, a little edgy, a lot more testimonials, a lot more activities. You can see this is one screen grab from the program. And again, we had very good success with that program. Here is the data on the follow-up. And what you should look at here is, of course, the comparison between the enhanced, which means the kind of tailored program, versus the basic. Now, what you see here is very interesting. For young users, there wasn't much difference between the two conditions, but the quit rates were still very, very good. And what we see here is that in the most conservative analysis you can do, we had almost 30% people totally abstinent from tobacco at 6 months follow-up using this web program. Now, many of you are interested in pharmacotherapy. That is, what should you use for nicotine replacement and what should you use to help people quit chew? Well, one of the problems here is that the Food and Drug Administration has no recommendations of any NRT for smokeless users. And so you might be kind of in the dark as to what is the right thing to do. And in fact, that's what I'd like to share with you. What we have done is we've done a series of studies. We've done studies on gum, nicotine patches, nicotine lozenges, bupropion, Chantix. We've done all of these studies. What we find is that the gum and patch don't really help make a significant improvement in cessation, but they do make a significant reduction in withdrawal symptoms, and people generally like the benefits that they get. But the most effective nicotine replacement product is the nicotine lozenges. And we've been using the 4 milligram mini lozenge, but we've also done studies with the full-size larger lozenge. We find that these are consistently effective. We now have multiple clinical trials showing that nicotine lozenges are the most effective. Bupropion has not been shown to be effective and should not be used for chewers, but varenicline or Chantix has been shown to be effective. But this is a prescription drug that requires a physician's prescription and is, of course, much more expensive. So we think that the lozenges would be the first choice. We recently are testing whether these lozenges enhance quitting if you provide this self-help and phone call support. Do the nicotine lozenges increase the quit rate over what we were doing before? And remember, what we were doing before is helping people with materials, providing phone call support. Now we want to know, do the lozenges help? And the answer is yes. The lozenges do enhance the quitting when people are quitting on their own. So even though they're having minimal assistance, minimal support, we find that the addition of the nicotine lozenge can significantly enhance the cessation rates. Now, one question a lot of people want to know is, do dual users have a harder time quitting? And in this case, what I'm pointing out is that people who both smoke and chew, we call them dual users. And here's an example of a recent study we did, and you can see the two columns here. Look under dual users, and you see that quit rates here are quite low. This is the chewers only. Now, these are people who only use oral tobacco, mostly snuff, and their quit rates were significantly higher than people who also smoke cigarettes. So what we find is that if people report smoking and chewing, that is, smoking and oral tobacco, then they're going to have a much harder time to quit, higher relapse rates, and you really need to work more intensively with them. So the implications for me are that you really have to be clear that the goal is to quit all tobacco. Really, with dual users, you have the risk that they'll quit their use of snuff and chew, but they'll just keep smoking. We do find that they're less likely to quit. They have a higher risk of relapse. And what we find is that you often need to use a combination of nicotine products, and that is the patch and lozenges or patch and gum. So if they're heavily dependent, then I think you need to use a combination of nicotine replacement products. Well, one of the things to remember here is that most of these users will have oral lesions. One study found that 75% of regular users after 3 years of use of snuff will have an identifiable oral lesion. We find that these lesions provide a lot of motivation to quit, and they're also very reinforcing when you quit. And so what we find is that this is a motivation, but also a reinforcement. We have what we call the 10-day rule, and that is that if you find a lesion or the dentist finds a lesion, if the person quits all tobacco use for a couple of weeks, you usually see a significant improvement where the lesion is. If you don't, obviously you should recommend a biopsy. We also want to emphasize that all these users will experience nicotine withdrawal. And NRT really does help reduce withdrawal. And I've recommended lozenges, but many people use nicotine gum. And nicotine gum, of course, comes in a variety of flavors. It comes in 2 and 4 milligram dosing. We recommend the 4 milligram dose. In general, what studies have shown is that lozenges deliver more nicotine to the person than gum. Even if, like if you compare a 4 milligram lozenge to a 4 milligram gum, the lozenge will deliver almost twice the active nicotine to the person. And I recommend oral substitutes. I think a lot of chewers really want something in their mouth. They want something that is kind of a substitute. And there's a wide range of substitutes you can recommend. And there is, of course, this fake chew kind of stuff which is available, which many people use. But there are other you don't have to buy things. You can use a variety of gums, a variety of other things. I've had people use toothpicks. We've had people use all kinds of oral substitutes just to have something in their mouth. And the truth is that many users will want to quit on their own, but they want support, they want help, and you can provide this with either self-help materials, guiding them to the web, providing phone support, which could be through the quit line or through your own counseling. And this is the enhancement for quitting. And sometimes some of this material may have to be used to help the partner provide the support to the person to quit. And I think just remember this, there's a lot of faces of addiction out there, and it's a very diverse audience of people that we're seeing who use chew and snuff. And I think the old stereotypes aren't there anymore. And what we're finding is that oral tobaccos are really reaching all parts of our culture. And so these are the faces of addiction that we really want to reach out and help people. And I'm now open to questions. I've gone very quickly, and I can go back to specific slides or elaborate as you will. I understand there will be questions, and I see that I have some right now that are listed here. Let's see, the My Last Dip program will continue. We don't have any materials to promote it, but we can send you the PDFs of promotional materials so that you can copy them and distribute them yourself. So many of you have used our My Last Dip program, and I appreciate that greatly. The truth is that that program is still live and still ready to go, so please feel free to use it. Let's see. I have a question here about patch and gum not being effective. Let's see. Yeah, the Mayo Clinic does have a document that includes dosing recommendations. I also have a dosing recommendation profile that I forgot to include in this, but if you send me an email, I can send you our dosing recommendations. There's no question that we generally under medicate for chewers. And I think what the Mayo people found was that generally the amount of gum and patches provided typically, if you use the standard dose for a smoker, that many chewers were not getting enough nicotine replacement. And that's why they were recommending even double patches on some people or the combination of patches and gum. And I would concur. I've worked with people at Mayo, and I concur with their clinical document. Let's see. The question is, does snus deliver lower nicotine content than other forms of ST? I think that's a question. That's a good question, and the answer is sometimes yes and sometimes no. We have been testing the snus products, and they vary. We've had, for example, Copenhagen snus appears to be a very low nicotine product. And Camel snus, when it first came out, was relatively low. But as they reformulated, the amount of nicotine in Camel snus increased. And particularly some of like General snus, which comes out of Sweden, very high levels of nicotine. So I think the answer to your question is that they vary widely and so on. Let's see. What are some of the that you somehow might be using with ST? I'm not quite sure. S and S. Let's see. Carrying. Not quite sure. Da, 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 da. Would you support the idea of recommending ST instead of cigarettes for smokers as a harm reduction? Oh, okay, that's an interesting question. I do get this question all the time about harm reduction, and I think it's a difficult one. The answer is that if you could get a person who is a daily heavy smoker to quit smoking and totally go over to oral tobacco, yes, it probably would have some harm reduction benefit. That is, when you're not combusting tobacco, then the risk of tobacco use in a non-combustible form is obviously better. That said, however, we do find that people who are smokers and then started using chew find themselves quite addicted to the chew and unable to quit. So, I still feel my goal is, of course, to help people quit all tobacco altogether. So that's my answer. How do chewers and smokers relate to each other in the same support group? That's an interesting question, Gary. I've had them together, and in general, because the kind of issues faced by people are pretty similar, I think that they can be together. I think they can provide support because the withdrawal symptoms, the nicotine addiction, much of what they're experiencing is the same, and I think the support. So I think they could be together. Mark, I'm happy to send you a copy of my scales and readiness ladder, and I think you have a copy of them on the slides. But if you send me an email, and my email address is right there, I'd be happy to send you a copy of those specific measures. Right. Let's see. Do you incorporate insulin resistance as part of your education when teaching diabetics about snuff? I really haven't dealt much with that. I do know that the sugar content can be very high, particularly in the loose leaf product, which is where we see the highest sugar content. And I have not really dealt much with that with regard to diabetic or teaching diabetics about snuff and chew. But certainly there's quite high sugar content, as you point out, Claire. Appreciate that comment. Why is smokeless tobacco more addictive than oral NRT products? That's a good question, Richard. I think the answer is that you have to think of these products as addiction, not in just from nicotine. Okay, it's very clear that pharmaceutical nicotine, that is the use of gum or lozenge, has nicotine, and you think, well, it's going to be addictive. But what's interesting is that I think it has to do with the flavoring of the product, and I think that the pH of the product, which delivers the nicotine much faster than the pharmaceutical nicotine. So essentially, pharmaceutical nicotine is a very poor substitute in terms of speed of delivery, the flavoring, and then you got the whole social aspect of using it with your friends, sharing it, the history of it being associated with pleasurable activities. So there's a strong conditioning that's hard to overcome. Let's see. Do you know if group work is effective in helping youth quit ST? We have run groups. I haven't done them for a while, but we used to do cessation groups for young people. I think it's very effective, and I think, again, providing that kind of support and that assistance and having people help each other provide that support and having people know that there are other people going through this treatment, I think can be very helpful. So my answer is that I think group work could be effective for young people. So I think that's good. Susan is asking, what is the half-life of a pinch of chew? Not quite sure how to answer that. I think the truth is that the half-life of nicotine, regardless of how you get it into your body, is the same. Maybe that's not what you're asking. But if you're asking about the nicotine half-life, then it's the same as for a smoker. And I didn't put a slide up today, but while the chewer takes up nicotine at a slightly slower rate, it is still quite rapid. And within 30 minutes, their rate, plasma nicotine level would be the same for a chewer or a smoker. I don't know if that answers your question, actually. But, guest number 2 says, can you explain some of the terminology involved in chewing? Well, I guess I'm not quite sure what terminology you might mean, but we refer to the tin of tobacco as snuff, and those people usually refer to themselves as dipping. Taking a dip is to take a pinch of tobacco and put it between your cheek and gum. Of course, now, so recently what you're finding is that many of these products are coming in prepackaged tea bags now as the more recent packaging to make it easier to use for people. But historically, you'd take a pinch between your of tobacco and put it between your cheek and gum, and that was called dipping. So let's see. The question is, do you use NRT with youth under age 18? Yes, I do. And the answer to that is that you usually will need parental consent, even though these are OTC, over-the-counter products. But we have used them for under age 18, and Mayo has also done studies like that. And we find that they're quite effective. Again, I think that assessing the dependence and making sure the youth is really dependent and addicted before providing NRT is a good idea. Does ST contain various toxic chemicals similar to cigarettes? Well, the answer is that there are toxins in snuff and chew, and they're what are called nitrosamines, which are very high levels and very highly cancerous. And those products are often unique. Some of the nitrosamines are tobacco-specific nitrosamines. That is, they don't occur in other products. But smoking by burning and combusting the tobacco does release unique toxic chemical mix and is more harmful and obviously faster uptake through the lungs. What's your experience with ST users with concurrent mental health disorders? I really don't have much experience with that. There is increasingly a an interest in comorbidity, that is, people who are experiencing psychological and mental health problems and their addiction to tobacco products. Most of that work is focused on smokers. I'm not aware of studies that have focused specifically on chewers. Let's see. Susan, you're asking, how do you determine level of addiction by the length of time? Yeah, the most important single item on that dependence scale, the Fagerstrom and other scales, is whether they use within 30 minutes of waking is probably the single most powerful item. But if you use my scale, there are certainly many other factors that I think you should really look at. Does the tea bag packaging help reduce the incidence of oral lesions? Joan, that's a great question. I don't know the answer. Um, I think that if the same chemical mix is in the product, that it would not protect you from oral lesions and that you would expect similar effects. On the other hand, the tobacco itself can be an irritant. That is, when people put large dips in their mouth between the cheek and gum, they may find that the tobacco itself is an irritant. So it's possible that the tea bag could reduce incidence of oral lesions. I don't think we really know because the widespread use of the tea bag packing is a fairly recent phenomena. So I don't think we're clear. Um, Let's see. Susan, you want me to clarify how long the client is out of bed before they will use tobacco? Yeah, I meant 30 minutes after waking. I don't define whether they're in bed or out of bed, I guess. But the truth is, I just say after you wake up within 30 minutes of waking. So that's kind of how I frame it. So these are great questions. This is a wonderful format for me to have the opportunity to answer questions like this. I apologize if I've missed some. There's so many questions that are being put on my screen that I might have missed one or two, but I will try to answer as many as I can.
I don't think you've missed any. I've been going through just to make sure.
Okay. Well, I might have, but people are typing away very rapidly. And it's great to see this much interest in the treatment of, smokeless tobacco cessation. So it's very good.
So one question we have is, can you recommend further readings on this topic?
Well, I just want to answer one question from Nick first, the last question posed. The question is there any truth to the rumor that the tobacco industry has added fiberglass to chew in order to increase absorption? Actually, Nick, the reason that that rumor got circulated, well, I don't know how it got circulated, but it's been a widespread rumor for a long time. And the answer is no. There's no evidence that the tobacco industry has ever added fiberglass. I have often been at presentations where I have to clarify that that is kind of a urban legend, if you will, or some legend from somewhere, but there is no evidence that that's been done. Any other question that I missed? Yeah. What was it that you asked me? I'm sorry, I was answering that last question from Nick.
If there's any additional readings that participants can refer to.
Well, sure. Let's see. You mean I have written some chapters and things about cessation. I recently wrote a chapter on cessation for a book that the CDC is coming out with, which they keep telling me they're going to publish any moment, but it's still not out. I guess I could find out if that chapter, if I could release that chapter separate from the book and make it available. If not, I could make another article which kind of summarizes cessation available. Let's see. Oh, people want to know about how to deal with hockey players. You know, Mona, I have no experience in dealing with hockey players. I've dealt with baseball players. I traveled with the National American League and actually used to do spring training. And I used to talk to baseball players. And we had dentists go with us to look for lesions in their mouth. It was a lot of fun doing it. I think I learned a lot and helped a lot of people, but I don't have any specific experience in dealing with hockey players. But I think if it's a cultural thing, that is, if hockey players are doing it widely and there's getting reinforcement for it, like young baseball players do, then I think you really have to deal with the coaches and the culture of hockey more than just helping one individual because they're in an environment in which there'll be a lot of support for chewing. So let's see. Joanne asks, do dentists generally target smoking? Yeah, they're probably more comfortable with smoking, but what I find is that because chewers have identifiable lesions, they actually find more comfort in identifying lesions and talking to their chewing patients than they do with smokers. And they can legally prescribe NRT therapy, and they can refer back to family docs. We generally find that they don't do that very much. NRT is available here over the counter. I assume in your country it's also available. But we do have a training program for dentists, a interactive training program for dentists and hygienists on how to provide tobacco cessation for their patients. So if you contact me, I can help you connect with that. Thank you very much today. It's been fun.
All right, I think we have one more question. Do you know the names of the fake ST products?
Yeah, no, I can send you a whole list with their websites and their products. There's a wide range of them, and they're in my quitting book. But the there's one called what is it called? Let's see, Back Off, BACC Off, which is a product that a lot of chewers really like. Um, there's Mint Snuff, which is a product I think made in Oregon, made of mint leaves and so on, is a popular product. Those are probably two of the most popular products. But if you're interested, I can send you or fax you a full list of the products and their contact information because a lot of times they're not available in the local stores. Yeah.
All right, that'd be great.
Yeah.
Well, thank you so much. That was a fantastic and very informative presentation. It was great to have so many questions that everyone could ask, get some answers.
Well, I went
So,
pretty fast, so I hope I've been able to answer your questions, but I tend to go pretty fast through my slides, so I hope you find it useful. But everybody has a copy of the slides, so they can review those on their own. Right.
yeah, for sure. So I just have a couple last housekeeping reminders. So a link to the online course evaluation is going to be sent to your email. So please complete that. Along with the course evaluation, you will also be sent a link to the learning assessment. In order to get your letter of completion, it is required that you do complete the second learning assessment. Since there's been so much feedback regarding the Readiness Ladder and some of the other assessment tools, along with the slides, we'll also send those and any other resources that have been mentioned today. I'll send those along so that everyone has those as well. If you participated as a group, please make sure to email Eleanor with a complete list of the participants by the end of the day so that you do get credit for your attendance. Our next Lunch and Learn webinar is going to be on November 20th, and it's going to be on tobacco interventions for patients with concurrent marijuana use, facilitated by Dr. Peter Selby. The application for that is already open, so please, if you are interested, register at our website, www.teachproject.ca. Thank you very much, and I hope that everyone has a great day. Thank you again, Herb, it was a fantastic presentation.
Thank you. Thank you. Should I go off? Yeah.